Managing hernias in the emergency department can be complex. Many different anatomical locations, and also many different ways to think about what needs to go to the OR, what doesn't, who should get scanned, who should get reduced. So, in this conversation with Dr. Beth Hochman, we discuss all of that. She is a professor at NYU Grossman School of Medicine for surgery. So excited to have you here. Let's get right into it. Maybe we can just start by if you can just run through a list of where you're looking on the body for various hernias.
Sure. Anatomically, the most common locations for hernias are the groin and the belly button. Then I also want to comment whether, if they have any surgical scars, whether they have an incisional hernia. That means a bulge under any surgical scar. So within the groin, um, there's two main categories. There's inguinal and femoral, and then within inguinal, the specific etiology is direct or indirect. Um, a lot of times, the ability to differentiate between any of those three, direct or indirect inguinal or ephemeral, is really difficult. And actually, there's yet another one that I didn't mention, obturator. So it can be, they all occur in the same area, but it can be very difficult to differentiate from the exam alone. And especially femoral and obturator hernias. Obturator hernias are the most sneaky because they can be really hard to even see on an exam. They're often identified on a CAT scan of somebody who comes in with an obstructive picture because those hernias are kind of tucked away.
Okay.
Fortunately, they are uncommon.
Okay. So it sounds like, you can have these different locations for your hernias, but how much do you change what you're doing based on the location or based on sort of the pathophysiology of what's happening within that hernia?
Yeah, the pathophysiology really dictates everything. The location does impact, what our surgical approach is going to be and our planning, but whether we're going to want to admit and operate now, admit and operate tomorrow, or send home and have somebody else operate on or us operate on later, that's all going to be dictated by the pathophysiology of what's happening currently. And so I think in my mind, that's more, what's the most relevant thing or concern, especially when somebody's in the ER. Um, so
So let's break
so
it down that way then. Instead of looking at it from a anatomical point of view, maybe you could describe sort of how you work through the pathophys.
yeah, absolutely. So generally what I think about when I hear that somebody has a hernia, when somebody tells me that we're being asked to see a patient who has a hernia, my immediate thought process is I want to know, is it reducible or not reducible? So, the top of the tree in my flow diagram for hernia evaluations is it reducible? I can push it in, or is it not reducible? In other words, incarcerated. So now reducible, automatically not worried. That person can go home and see a surgeon as an outpatient. But if we're in the not reducible, aka incarcerated arm, then now I want to know, is it um, acute or chronic? Because if it's chronic and unchanged from what it was before, I'm not worried. But if it's acute, I'm interested. Now I want to know more. So we've gone reducible, not reducible, aka incarcerated. Within incarcerated, is it acute or chronic? Chronic, I'm not worried about. Acute, I'm worried about. Now I want to know within acute, is it obstructing or not obstructing? If it's not obstructing, not so worried. I'm definitely going to want more information about that person because it's an acute hernia. But if it's not obstructing, they're not on my emergent intervention list. If it's obstructing, I'm going to be worried that is a hernia that is acutely trapping bowel that is causing obstruction, and also now that bowel is potentially threatened and potentially can become strangulated. So that's the person that I'm going to want to jump to quickly, and I'm going to want to try to reduce if they haven't already been reduced. Then the other thing I'm worried about in somebody who has an acute incarcerated hernia, and especially an acute incarcerated obstructing one, is I'm worried how long that process has been going on and how severe their symptoms are, because that tells me two things. One, how likely I'll be successful at a bedside attempt at reduction. And two, how worried I am that the bowel that's trapped in there is already dead. Um, if they've been experiencing these symptoms for a long time, meaning several hours or days, I'm going to be more worried. And then I'm going to be even more worried if the skin overlying the area is red or if the person has evidence of sepsis or SIRS, because that would go along with there's something already dead in there.
That's great. Okay. So I think from here, we can run through some cases to sort of dive in a little bit deeper to each of those scenarios and really flesh out some of the confusing points about them.
Sure, I love it. So I guess, the first version of hernias I would say is, let's say somebody comes in to you. Let's make it really simple. Let's say this is a 25-year-old, otherwise completely healthy male who says that he was doing a bunch of weightlifting, and just suddenly noticed a bulge in his groin, and he is dismayed, to say the least, by the presence of this new bulge that was not there yesterday. And he's so freaked out, but he doesn't want to touch it. It's just like the whole thing is freaking him out. What would be your first approach to somebody like that?
So I think I would, be looking at where is the location of the hernia, trying to classify it in terms of is this, it sounds like we're talking about an inguinal hernia, whether it could be direct or indirect. And then trying to assess is this hernia soft? Is it reducible? Is it not reducible? And also if they're having any symptoms like vomiting or difficulty passing gas.
Yeah, awesome. Exactly. So the most important things to ask are what you just mentioned. Are they having obstructive symptoms? So nausea, vomiting, difficulty passing gas or stool. Um, and then just pain in the area. Sometimes, like this guy, this patient that I'm presenting is a young, healthy guy who is just so freaked out by the presence of it, he can't even enumerate whether it's painful or not, and is afraid to even try pushing it in. But patients who have seen a hernia before or know that they have one might see that and be like, "Oh, yeah, of course," and just push it back in and move on with their day. So this is a young guy who's like, "Oh my god." So yeah, even before asking the obstructive symptoms, I might just ask him, has this ever happened to you before? And if it has, what happened? What did you do? And if it hasn't, did you try pushing it in?
Now, how important is it for you if let's say you rule out those obstructive symptoms in this patient and it's the first time, it's not very painful, hasn't tried to push it back in. How important is it for us in the emergency department to be able to reduce that hernia before we can discharge the patient?
So, I would say that that's the critical piece. If you can reduce it, everybody's golden, and that guy can go straight home. And you can just have them go see somebody as an outpatient, to plan for any kind of surgical repair. The earlier you reduce it, two things happen. You are addressing that person's pain and anxiety immediately. Like the sooner you get to it, the sooner you're helping that person. And then secondly, if it's been stuck for a long time, or we're worried that it's there's actually something in there that's threatened. The sooner you push it in, the less threatened that trapped item is going to be.
Would you share any sort of tips and tricks for how you go about reducing these hernias? I know these can be in various locations, but how do you think through, okay, I'm going to try to reduce this hernia?
Yeah. Well, so first of all, so usually what I do is obviously warn the patient that or preempt the patient that I'm going to be examining the area. That first I just want to understand, what everything looks like, and then that they're going to feel some pressure. And I don't my initial attempt is some pretty consistent but firm pressure on the area to see if it just pops right in. Or also to see how tender it is, because sometimes these aren't really that tender. It's just simply the appearance of a bulge that shouldn't be where, or hasn't been there before, that really can be upsetting to people. So knowing that it's not tender or tender is a very important first step. There are some patients, not the one that I described, but let's say you have an older patient, who may or may not really have noticed that he has a hernia. Um, just sort of appreciated that the area has gotten more swollen over the years, but it hasn't really bothered him at all. Um, that might be somebody who has had a very chronic, what we call inguinal hernia, and so the whole thing is like a giant firm bulge. Um, if they say like, oh yeah, it's looked like that for 10 years, then you know, first of all, this is not an emergency. This is not newly present. And secondly, this might not be something that's actually reducible. This might be something that is just chronically incarcerated. But the guy that I was initially describing, somebody who this is a brand new bulge, never seen it before, and it was a completely flat area before. Um, that's somebody who you would imagine should be able to get reduced. And then the the direction in which I try to apply pressure is the other key feature. So trying to place pressure in such a way that it's going to reduce the hernia along the inguinal canal is going to be your most successful bet. Now, you don't necessarily know if it's direct or indirect, so that's not always entirely necessary, but you can't go wrong.
Let me ask about that, just to make that distinction between when we're talking about inguinal hernias, direct and indirect. Is it I mean, is a direct hernia always sort of just gonna be a bulge in that suprapubic area versus an an indirect is gonna be in the scrotum, or is it you can't really make that distinction just by looking at it?
Oh, yeah, honestly, most of the time or oftentimes you really can't make that distinction just by looking at it. Because the end result is the bulge or the contents of the hernia are going to land in the same endpoint, whether they're starting from a direct defect or an indirect defect. So when you're just looking at it, you're basically just saying this is a small hernia or a large hernia. But you can't really say just looking at it the source of it. And there's many people who have something called pantaloon hernias where it's both indirect and direct.
Okay, so it doesn't sound like that distinction is super important, but you're saying to find sort of the source of the hernia and try to reduce it in that direction, it sounds like.
Exactly, exactly. And so that's also what is relevant regardless of where the hernia is. So if we're talking, let's say we have somebody who came in, it's not a guy who was working out in the gym. This is now, somebody a woman who had um a C-section uh a long time ago through a inferior midline incision instead of a fan and steel. And has a new bulge that she didn't appreciate before. So that incisional hernia, exact same thing. You're looking at it and the thought process is, okay, which direction do I need to push in order to get this to go back in? It's through the, if it's coming up through an incision, I want to push it down back into that incision.
And I've heard things about sort of trying to grab the hernia, and sort of pinch it a little bit before you push it.
Yeah, that can be super helpful. It really depends on how big the hernia is and the contents or so meaning like if you have a significant amount of fat in the hernia as opposed to bowel or um and if it's been trapped for a while, the longer something's been trapped, often it gets a little bit swollen and it can be harder to kind of pinch the way you were describing. And so I think the concept behind the pinching maneuver is sort of like allowing yourself to direct your pressure against one area as opposed to just just grabbing the whole bulge and trying to ram the whole thing back.
So let's take in this example of a 25-year-old guy, he's got a hernia that's more frightening to him than painful, no obstructive symptoms. Is it okay if we cannot reduce that hernia, in the ED? Is it okay to send them out to see you, in a week?
That guy I would not send home without reducing first. The reason being because the way he presented, we know this is a new bulge, and until it's been reduced, it is now a newly incarcerated hernia until we prove otherwise. So a newly incarcerated hernia might not have symptoms right now, but give him a few hours, and whatever's stuck in there is going to start hurting. And depending on what's stuck in there, he's going to start having more symptoms. So that's somebody you would not want to send home until you've proven that this is in fact reducible. It's the older gentleman who has had this bulge forever and it actually doesn't look any different than it ever did before. That's the one that, you don't have to worry about trying to reduce that because if it's not actually causing any new symptoms, um, and it's not a different size than it normally is for that person, then it's almost assuredly not an acute problem.
So that sort of calls into question another thing in my mind, which is what is the distinction between an irreducible hernia and an incarcerated hernia in that case?
Oh, so they are the same. It's the distinction is it acutely incarcerated or chronically incarcerated?
Got it.
So acute incarceration you have no idea what's stuck and you have no idea what's going to happen if you let it sit. And so that's the one where you're like, is it actually like wedged in there and we need to do something? Versus the chronically incarcerated is the one where this is just it's been stuck out so long. There's now this like thick rind inside, of a hernia sac that's containing all the stuff. But as long as the person is not having those obstructive symptoms or having new pain, or the bulge is not acutely a different size, then you can say with confidence this is a chronic situation rather than an acute situation.
Got it. Okay, so that's super interesting. So a new hernia without obstructive symptoms, if it's acutely incarcerated, in other words, it's out, you can't get it back, it's more important to get that acutely incarcerated one back in than something that's been there for years chronically and you don't anticipate it getting worse acutely. It sort of just is what it is.
Exactly, exactly. And in both
Okay.
of those circumstances, you're gonna refer this person to a surgeon.
Okay, so let's run through another variation of a case
Sure.
here.
Yeah. So now let's say I'm gonna take this guy, I'm gonna make him a little older. We're gonna say he's now, I don't know, let's make him 53, and he has hypertension, he has diabetes, he's a little overweight. He knew he had a hernia, but now today, it is bigger than normal, and when he tried to push it in like he normally does, he couldn't get it to go back in. And it's really hurting.
Oh, so this is someone, I think if you're talking about someone a little older, some comorbidities, and their hernia is acutely changing and very painful, I'm worried about a worsening incarceration or potentially a strangulation. So I think for this patient, I'm going to obviously ask about obstructive symptoms, but either way, it sounds like someone I'm going to CT to take a look and see exactly what's going on.
Yeah, I totally agree. And the one thing I might say is you don't actually need the CT first. You can try to reduce this patient's hernia first. I think that a really important detail is understanding how long he's had symptoms and what specifically the symptoms are. So if he tells you, "God, it's just hurting really bad right where the bulge is, but it doesn't hurt anywhere else," that tells you a couple things. It tells you what you said, like, that there's something threatened in there. And when we say strangulated, what we mean is the thing that's threatened actually has had its circulation cut off, is actually dead. So that's the main difference there. Incarcerated and threatened is kind of the best thing that we can offer in terms of a diagnosis in somebody who we have not actually operated. You can't actually say with certainty that there's strangulation, that the tissue is truly dead until you're looking at that dead tissue in your hands in the operating room.
This is where I get a little caught up is that, what I learned, at least in medical school, is sort of, all right, if it's incarcerated, you need to reduce it. But if it's strangulated, do not reduce it. And you're looking at something that's tender and you're asking yourself, well, how am I supposed to know if this is strangulated, in which case I should never reduce it, or incarcerated, in which case
Yeah.
I must reduce it?
Yeah, so this is the thing that confuses everybody. The reality is like determining from the outside whether something is strangulated is really difficult. You cannot say with certainty that something's strangulated until you're holding it in your hands in the OR. But there are some signs that can tell you, wow, this is definitely strangulated. Again, meaning the tissue's already dead. It is irreversibly dead. Um, and those things are if the skin overlying the hernia has changed color, is red, that tells you that there's something dead underneath it. And then lab work can also be informative. So if somebody has a super high white count, or if they're SIRSy, if they're, having fever, tachycardia, et cetera, that tells you that
Sure.
something is definitely not going great. So that's the person that you might leave alone and scan first.
I guess in the absence of those obvious toxic signs, do you
Yeah.
feel like it's okay to push on this thing and try your best to reduce it?
Yeah, I certainly would. And I would say there's no harm, in my opinion. Others may disagree, but in my opinion, there's no harm in trying to reduce it um, in that moment. If there's no overt signs of underlying strangulation, as I mentioned, there's no harm in trying to reduce a incarcerated hernia, because the best case scenario is you just took somebody from being threatened, um, of strangulation, and resolved that problem. You allowed them to allowed whatever was caught to now resume having circulation, and you've now saved their life. So that's, best case scenario. Worst case scenario is you successfully reduce something that was already dead, and now they're going to continue to have symptoms, and they still need to go to the OR. Um, so like you would still call surgery to meet this person, and you wouldn't reduce something that's dead, and then the person would suddenly feel better and be totally normal, right? Like
That's a
there's
good
no
way
way
of
that would
thinking about
happen.
it.
Yeah,
Right. So like if the person did have strangulation, it is dead gut, you're gonna reduce it and their pain is just gonna keep getting worse.
exactly. So it doesn't change what
Right.
we do. The other thing is usually if something has been incarcerated long enough to be strangulated, it's not reducible. Because by virtue of being incarcerated for that long, there's edema in the tissues that have been stuck. And that's precisely what prevents them from being reduced. So, in my opinion, it's basically always worth trying because
Got it.
you're only going to potentially make the situation better, but you're not going to make the situation worse. The teaching used to be, and some people probably do feel this way, um, was like, well, if you reduce something that's dead and it was like perforated, for example, now you've just reduced something that's going to be like freely leaking all over the belly. But my response to that is this person already had that thing freely leaking in their hernia sac, and it was going to be freely leaking in their belly anyway. So like that, you're not solving any problems.
And do you have any tips or tricks now for just physically reducing those hernias that are, in this patient, a lot more tender, a lot more sort of inflamed? How do you go about that? Because those patients it can be a very painful experience for them.
Yeah. So I guess I would, first of all, I would say, if you're similar to what I was saying before, if it is too painful for the person for you to be able to successfully try reducing, that's enough information. That's given you what you need, and you can, continue onward with the rest of your with the rest of the approach. Getting a scan, calling surgery. You would call us anyway. But when you're attempting to reduce, some of the strategies that are very helpful is, especially with an inguinal hernia, in particular, is tilting the person so that their head down, pre-medicating them with some systemic pain medication, like so give them a dose of whatever is your narcotic du jour, morphine, Dilaudid, whatever, and putting an ice pack on the area because that can potentially reduce a little bit of the edema slash also make it more comfortable for the patient. And then the actual approach to reduction is really just kind of firm, continuous pressure on the area. Again, trying to reduce it along the direction of the source of the hernia. So when you're dealing with an inguinal hernia, you're pushing upwards towards the inguinal canal, and just slow, consistent pressure. And if that's too painful or you're not making any progress, that was a good faith effort. That's enough. So
If
I
it
think
saves them a trip to the OR, it's probably worth it.
exactly. Yes, exactly.
So in this patient, would you suggest, it sounds like this person's heading this older patient, very tender, you're going to try to reduce it. Obviously, if you can't reduce it, you're going to CT them. But if you do reduce it, would you not CT that patient?
No, I would only
Okay.
CT them if they were having other symptoms that I couldn't really explain, or they were still having ongoing symptoms. The people that I would scan would be, in addition to somebody whose symptoms don't make sense, would be somebody who has prior surgical history, and especially somebody who's already had a hernia repaired. That's somebody who I would get a scan because it does help with our surgical planning.
Got it. Okay, let's run through a different variation.
So, okay, so let's think about now I'm gonna add to what I just said before in terms of sometimes there's another process happening. So let's say you have a person with um, metastatic ovarian cancer, and ascites, and they now have this new bulge in their groin that wasn't present before. It is definitely uncomfortable, and they kind of always have nausea and always have bloating.
Well, that's
How about you?
interesting because, that could be a metastasis, that could be a hernia. I mean, I think that's someone you got to scan. Now I'm just saying, I'm
Yeah.
sounding like the guy who wants to scan everyone, but I don't know.
No. Yeah, no, but I agree. Like that's clearly somebody you got to scan because you have no idea what's happening.
Let me ask you this because, when we get these scans, so we see a lot of different things in these hernias, whether it's a ventral hernia, an umbilical hernia, an inguinal hernia, a Spigelian hernia, wherever the hernia is, we could see it can be a fat containing hernia, it can be a bowel containing hernia. Like, how do you interpret what you see there in terms of what you're going to do next?
Yeah, that's a great question. So, I mean, location is a little bit less important. In fact, a lot less important than what's actually stuck. And if it's just fat, automatically not worried. Um,
Tell me more about that.
so fat, any fat that's trapped, even if it's totally incarcerated and strangulated, is not something that's going to be life threatening to the person. The worst case scenario is it causes a lot of pain because that fat, as it's dying, is uncomfortable, and could, in theory, get infected depending on other things that are, circulating in the person's body.
Yes.
But in theory, that is just a sterile little nubbin of fat that's going to die off and um, not pose any risk to the person.
Interesting. Even if it's strangulated, even if it's kind of necrotic, it doesn't bother you as much. You may operate on them at some point, but that's not an emergency to you.
It's not an emergency to me. I can prioritize somebody else over this one. I'm not worried that this one's going to be super sick right away. Um,
Okay.
and also when it's just fat, the likelihood that they're even going to be super sick is low. It's non-zero, but it's low. And so the things that I look for in that patient to determine, can I send this person home or do I need to admit them, is their pain uncontrolled?
Okay, so we talked a lot about the fat containing hernias. Let's talk about bowel containing hernias. So obviously in my mind, I'm going to divide that initially between obstructed bowel and non-obstructed bowel. But how else do you see, when you see bowel in a hernia on a CT, what are you looking at? How are you thinking through your different sort of pathways there?
Yeah. Yeah. I have the same dichotomy. My first question is it obstructing or non-obstructing? If it's non-obstructing, I am also automatically less concerned. Because if you think about it, by definition, in order for something to be caught so much that it's potentially going to have the circulation cut off, that means that it's going to be blocked and it's going to start getting obstructed. So, it has to be incarcerated in a way that is uh, leading to obstruction in order to really be threatening.
So you
Um,
mean if it's not obstructed, it's pretty hard for it to be strangulated.
correct, correct,
Got it.
exactly. Um,
Okay.
so when I see that it's not obstructed, I'm automatically lower level of concern about that person. But if there's evidence of obstruction, if they're having nausea, vomiting, bloating, or if you see on a scan that there's bowel entering a hernia, um, an exit, like entering the bowel proximal to the hernia is dilated and the bowel distal to the hernia is decompressed, that is an obstructing hernia, and that's a person that I will for sure be admitting to the hospital and operating at some point, if not urgently, if not emergently, then urgently.
And
And
you might try to decompress with NG tube and reduce it bedside,
correct,
potentially? Right.
correct, correct. Even if I was successful at reducing that person bedside, I anybody that comes in with an acutely incarcerated obstructing hernia is somebody that needs surgery, needs a surgical repair, that admission, unless there's some really extenuating circumstances. Because that's somebody who's going to come right back again 3 days from now with the same problem,
Right.
and potentially no worse.
Oh, you're saying even if you reduce it, they need to repair that.
Yeah, 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 exactly. If I reduce it, then I can say, "Oh, great, we're all going to sleep tonight. We'll fix that tomorrow." But if I can't reduce it, then I'm going to be like, "Ugh, and we got to take care of that today before that bowel that's already squished enough to be obstructing doesn't become strangulated."
Got it. All right. Well, thank you so much for doing this. This was awesome. You're great.
No problem.
Ah.
Thanks. Thanks. My pleasure.